Hello, everybody. My name is Avi, and I'll be presenting on the impact of international aid in Liberia's health sector. To start with a bit about me, I live in Falls Church, Virginia, and am a rising senior at the Potomac School. Within the public health and health policy space, some of my work includes being a research intern at the Johns Hopkins Medicare Advantage Data Lab, as well as being the public health policy lead at the Institute for Youth and Policy. I've also co-founded Miles Count, a running nonprofit for adaptive runners, and am involved in my school's student government, and hope to pursue a career asking and solving big picture questions about health policy and global public health. So let's begin with some background on Liberia's health system. Liberia experienced civil war for 14 years, ending in 2003, devastating the health sector. To put this effect into perspective, at the war's end, there were only 30 physicians in the country who were supposed to treat a population of over 3 million. In the coming years, international aid and programming in Liberia to rebuild the health sector rapidly grew, with dozens of international organizations and NGOs establishing programs in the country. The Ebola epidemic exposed the shortcomings that still existed, though, killing over 4.8 thousand people in Liberia, largely due to an estimated 50% decrease in health service accessibility. Worse, these events have left a fear in the Liberian population that the health system will not meet their needs. And it's visible today. There isn't enough infrastructure, there aren't enough doctors, and there isn't enough trust in the system. The question to ask is why, after billions of dollars of investment, does the Liberian health sector experience the same fundamental challenges that it did 2 decades ago? First, though, we must acknowledge that Liberia has experienced short-term growth, most notably between the Ebola epidemic and COVID-19 pandemic. COVID-19 had just 6% of the mortality that the contact-based Ebola had, meaning that the much more virulent disease had a significantly smaller impact. It's easy to attribute to the success to the growth in international aid. Hospitals were constructed, rapid response systems were built, and education programs were producing more doctors to treat the sick. Importantly, though, that means that much of this programming was vertical, benefiting singular areas of need, rather than developing structural changes to the system as a whole. This is important because from COVID to the present, it is clear that the health system has not maintained its growth. And it's interesting, Liberians tend to think that aid is far less effective than the international community does. Their perspective identifies three key themes to explain aid's long-term ineffectiveness. First, members of the Liberian government are openly critical of the administration of aid. The health sector has been chronically underfunded, and up to 70% of aid money is allocated to administrative costs, leaving just a fraction to be used to develop programs themselves. Second, the overriding sentiment of corruption in both the government and aid organizations has led to increased off-budget spending, money that goes directly to Liberian communities and not through the government. This means that Liberian communities have a lack of oversight in the implementation process, impacting now 75% of all health sector expenditure in the country. Finally, patients, including pregnant mothers, reveal harrowing stories of being upcharged at hospitals, feeling much safer with traditional healers and community midwives. Altogether, it means that most aid money is either spent within the government or allocated around it, preventing the interoperability of systems and creating unnecessary redundancy. In the Health Workforce Program Strategy of 2016, this looks like funding a pathology lab without actually developing a pathologist to work in it, wasting money and leaving little impact. Of the services that do end up materializing, they almost universally face an uphill battle in building trust with patients, a systematic challenge that aid has only made more difficult. I want to highlight this top picture as well. This is a photo we took at the TB Annex in Monrovia. There are patients with MDR TB in that blue and white building. At other TB annexes across the world, this entire place would be heavily sanitized. But here, you see doctors with blue paper masks walking in and out, and you can recognize that in places that are the most vulnerable, there's a devastating lack of infrastructure. But beyond implementation, I found that the structure of aid programs is a cause for their long-term failure. When 68% of Liberia's health sector funding is external, there is a clear dependency formed. Dependency is dangerous. Organizational programs typically run for just 3 to 5 years and then require a second grant to be reinstated, largely because aid is reactionary. The graph on the right shows that after the Ebola and COVID-19 outbreaks, the amount of aid in the country decreased rapidly. Oftentimes, this leaves unfinished projects and little sustained impact after the organization departs. Quite simply, international actors are more driven by money than by progress. And when their grants expire, so does their aid. During the projects, donors are also incentivized to work vertically and not horizontally. This is because donors have a responsibility to their beneficiaries to deliver a clear, tangible impact, like how many vaccines they administer or how many hospital beds they sponsor. It's much harder to quantify a structural change, especially because it frequently takes years to see an impact materialize. When donors choose to take the easier vertical and temporary solution, it's no surprise that long-term aid, which has been disincentivized, does not occur. In an interview with former USAID program manager in Liberia, he explained to me that the system is intentional, arguing that donors benefit by maintaining a broken system, demonstrated by their predatory loaning strategies. So why is this uniquely important now? Well, recently, the USAID shutdown has caused Liberia's health sector to lose over $100 million, money that the government can't replace. Five of Liberia's 15 counties will now be left without any healthcare sector budget at all. And USAID is just a microcosm of the broader systemic issue. The relationship between Liberia and international donors should be mutually beneficial, not one-sided and predatory. It's why a dangerous 56% of health facilities still lack proper medication to treat their patients. And it's why a catastrophic 60% of health expenditure is still out-of-pocket spending. And it's why in 2 decades, basic health services are largely unavailable, despite hundreds of aid packages being delivered. Although international collaboration has addressed shortcomings in the health sector exposed by the Ebola epidemic, the structure of aid packages and implementation of the aid itself sustained instability that leaves the country vulnerable to future health crises due to the perpetuation of a hierarchy within international aid relations. Below are references, and here are many of the people I had the opportunity to learn from and interview while in Liberia. I'm especially grateful to Luke Kringer, who invited me to Liberia with open arms and has always been willing to teach me more about their health system. Thank you all so much for listening, and my contact information is listed here. I'm very appreciative of your time, and I hope you are inspired to question how to build a health system.